Well, ladies and gentlemen, now we're going to discuss our approach to the description of congenital cardiac malformations. So this is a question that I asked a long time ago when I was beginning my career. Are the lesions with which we're confronted difficult to understand? I hope you will agree with me that it is still the case that simple lesions give no problems. What do we mean by simple lesions? We can think about septal defects, although it's true we still argue how best to describe the variants of septal defects, but we can recognize them and we know where they are. Certainly obstructive lesions have never given us any problems, and we've always been able to cope with patency of the arterial duct. But when I started in my career, there was colossal confusion as to how best we should describe those lesions that were considered to be complex. So what represents complexity? It's when you find a patient when the heart is in the wrong place, the chambers aren't where you expect them to be, and in most circumstances, the blood is going the wrong way round. And when I started, we used to have a category in which these things were often put that was called miscellaneous. But you're all well aware that that is no longer the case. So what happened when I was starting in my career was that it was first suggested that we should approach all of these lesions in logical fashion. And the answer to all that, of course, was segmental analysis. And you will all be aware that segmental analysis was introduced by Richard and Stella van Praag. I met Richard van Praag when I began my career in 1974. Sadly, Richard passed on just a couple of months ago, but his contributions to the understanding of the congenitally malformed heart are colossal. And here's a nice picture of Richard with his wife Stella, and you will all know that they worked together for very many years at Boston Children's Hospital. And they introduced the notion of the segmental approach. And what they were suggesting was that we should analyze the heart in 3 segments. Because they'd noted that if you took the heart apart and you looked at these segments, there was very limited variability in each of those segments. And by the same token, there were very limited ways in which they could be joined together. But there was an unlimited combination of associated lesions. So Richard and Stella introduced this notion that we should begin our analysis of all the patients with congenital heart disease by working out the basic template. And that's what they did with their segmental analysis. So here are their segments. As you know, we start off with the atriums. We move on, we look at the ventricular mass, and then we complete our analysis by looking at the arterial trunks. So the segments are important. Now, when I started in my career, as I say, and I keep on repeating this, it was a long time ago, we appreciated that not only were the segments important, but also the junctions between them were perhaps of greater importance. And it so happens that that coincided with the appearance of cross-sectional echocardiography. Prior to that, angiography had been the first port of call when seeking to analyze the congenitally malformed heart. But now suddenly, for the first time, with far greater accuracy, you could look at the way the segments were joined together. So my colleagues and I, in the mid-1970s, suggested that not only did we need the segmental approach, but we need to modify it in such a way that we could look at the junctions, and we called that, as you see in the title of my slides, the sequential segmental approach. And at the time, we thought we were doing no more than to make a slight modification in the approach that Richard himself had promoted, this segmental approach. But as I will explain, we were confronted with a problem that we didn't fully appreciate at the time, and it was that problem that spawned what we might consider the Great Schism, but hopefully we can now resolve that schism. So we took the segments, and our sequential approach started with the segments, but then we looked at the way they were joined together. We analyzed what was going on at the atrioventricular, ventricular arterial junctions, and we called those the connections. And so, from the outset, we had to understand what was going on in the segments. And the first question we had to ask, how do we distinguish between the chambers? And here we use the most constant feature for recognition. We didn't always do this, but because the most constant feature is not necessarily the most obvious. And as an example of that, we can consider the left atrium. Because when we started, and still often in the segmental approach, it is the venous connections that are considered to be the major feature of the atrial chambers. But let me show you a heart. This is a heart where the ventricular mass has been tipped out of its pericardial cradle. This is the so-called Tausig maneuver. And what you now see at the back of the pericardium are the pulmonary veins. And I hope you will all recognize that the pulmonary veins are turning south. They are draining to an extra cardiac site. But if you were using the pulmonary venous connection in this instance to define the left atrium, you'd have to call the liver the left atrium. Because, of course, this is totally anomalous pulmonary venous connection to the hepatic portal system. But despite the fact that the veins are going into the liver, we can still recognize the left atrium. So this led us to use the morphological method when seeking to distinguish between the segments, the chambers, or the components of the cardiac segments. So now, always, we use the most constant component to distinguish what is morphologically right, what is morphologically left. We do not use another feature that itself is variable. Why do we do this? Because we were pointed in this direction again by Richard van Praagh. And Richard criticized one of the manuscripts we'd written about double inlet right ventricle, pointing out a mistake where we had used one variable feature to define another. And we immediately recognized the significance of this approach, and ever since then, we have used the morphological method. So when we're analyzing the atrium, we look at these various parts and we ask which is the most constant. And you will all know that it is the appendage that is the most constant atrial component. And if we simply look in the autopsy room, the morphologically right atrium, which you see to your left hand, the morphologically left atrium, which you see to your right hand, we can distinguish the two simply on the basis of their shape. So in most instances, shape is sufficient to distinguish the appendages. But Richard van Praagh again was not happy with this approach we were taking, because he pointed out that shape could be changed by abnormal hemodynamics. So we asked the question, is there a better way to distinguish between the atrial chambers? And a Japanese fellow who came and worked with me in London, called Hideki Uemura, pointed out on analyzing a large series of hearts that if you look at the right atrioventricular junction, as you now see to your left hand, the pectinate muscles in the morphologically right atrium go all the way around the atrioventricular junction. And that is what makes this atrial chamber morphologically right. If you compare that with the chamber on the other side of the heart, the pectinate muscles are confined within the tubular appendage. The vestibule is smooth, and that makes this chamber morphologically left. So now it is the extent of the pectinate muscles we use to distinguish between the morphologically right and left atrial chambers. It may not always be easy for you to do this, but I think now, as resolution of your clinical techniques gets better and better, it is possible to distinguish the pectinate muscles, or, in the question of the morphologically left atrium, to find the coronary sinus in the left atrioventricular groove. So it does work if you know what you are looking for. We had another big problem with the ventricular mass. First, we have to decide how extensive is the ventricular mass, and then we have to agree on how many components there are. So when we look at the ventricular mass, we take the stance that it starts at the atrioventricular junction and it extends to the ventricular arterial junction. And then as you look at this morphologically right ventricle, it has an obvious inlet, it has an apical component, and it has an outlet, which in the morphologically right ventricle is the tubular infundibular sleeve. If we then look at the morphologically left ventricle, again it extends from the atrioventricular, the ventricular arterial junctions, and once more it has inlet, apical trabecular component, and an abbreviated outlet, but still an outlet. And we know that within the ventricular mass, it is the apical component that is most constant. So that is what we use to determine morphologically leftness or rightness. There's then another very important component of the ventricular mass, because we can also look at the way that those other two components are related to the apical component, and that determines what we call ventricular topology. In Van Prague notation, this is ventricular handedness or looping. And so we know that in most instances, it is the right hand that fits on the septal surface of the right ventricle, such that the thumb goes in the inlet, the fingers go in the outlet when the palm is laid on the septal surface. And that is what we use to determine right-handed ventricular topology. And it's then obvious that in a very small minority of cases, the ventricular mass is mirror imaged. So then, when we look at the morphologically right ventricle, it is the left hand that goes on the septal surface in comparable fashion, giving us left-handed ventricular topology. So these are the terms we use to describe what's going on within the ventricular mass. And we also know that normal ventricles possess each of those three parts, but they're not always of normal size. Abnormal ventricles, in contrast, have the inlet and outlet components shared between them. And that means that one ventricle becomes dominant, the other ventricle is not only hypoplastic, but is incomplete. And that tells us the hearts that have one big and one small ventricle are not anatomically univentricular, although, as we will discuss, frequently they have a univentricular atrioventricular connection. But it is the tripartite approach that resolves any problems we have with ventricular description. Now, when we come on to the arterial segment, we have a problem because there are no intrinsic features that tell us the difference between one or another arterial trunk. They are all arterial, but we can distinguish them on the basis of the way they branch. So the trunk that gives rise to the coronary arteries and the brachiocephalic arteries is the aorta. The trunk that branches to give rise to the vessels that supply the lungs is the pulmonary trunk. On occasion, an arterial trunk can branch so to give rise to coronary arteries, systemic arteries, and pulmonary arteries. And so this is a common arterial trunk. And then we have to take note of that situation in which there is total absence of the intrapericardial pulmonary arteries. And in this instance, the only sensible way of describing this entity is to consider it as a solitary arterial trunk, but to all intents and purposes, it functions as an aorta. So we have the ways and means to determine what is morphologically right, what is morphologically left, all for the arterial segments, the nature of those arterial trunks. Now, the analysis is not complete without putting that into the body, because in most instances, the appendages are congruent with the bodily organs. So this gives you a good idea of what is going on when you simply look at bodily arrangement. And in terms of bodily arrangement, there are four basic approaches, four basic systems. The first is the usual. I'm sure you still call that solitus, but it's surely better these days to talk American. That's particularly important when we consider its mirror image, because these patients do not have upside downness, which is what we mean by inversion. They truly have mirror imagery. But they are very rare. Much more frequently, when we have complex congenital malformation, we have one or other of these arrangements. And they used to be identified on the basis of the spleen. Nowadays, we know that in these settings, the bodily organs, including, as I'm going to show you, the atrial appendages, are isomeric. But we also know that the associations are not always uniform. Whenever we are in doubt, we describe each system. So we have these four basic arrangements. Here you see the situation where the right-sided lung is trilobed, fed by a short bronchus. The left-sided lung is bilobed with a long bronchus. The liver is on the right, stomach and spleen are on the left, and the atrial appendages match that. And this is the usual arrangement. And so you'll appreciate that when that is mirror imaged, the trilobed lung with the short bronchus is on the left side, the bilobed lung with the long bronchus is on the right side, the abdominal organs are mirror imaged, and so are the atrial appendages. So this is mirror imagery. And then in the arrangements that I'm sure many of you still call heterotaxy. Heterotaxy is not an ideal word because it means other than usual. There is a much better way of describing these arrangements because, as you see, in one set, each of the lungs is trilobed, each has a short bronchus. When we look below the diaphragm, there is usually, but not always, absence of the spleen. The liver is midlined, and the gut is malrotated. But when we look within the heart, we find isomeric right atrial appendages. So this is right isomerism. And the counterpart of that is when we have bilateral morphologically left lungs, multiple spleens, again with a malrotated gut, but this time with bilateral morphologically left appendages, giving us left isomerism. So when we look within the heart, the associations with the bodily organs are not always sufficiently constant to permit us to use the spleen, and there is no such thing as an ambiguous arrangement. We are forced to start logical analysis of the heart with the appendages. And then, in most instances, we find that the pectinate muscles run to the crux on the right, the left-sided vestibule is smooth, so that is the usual arrangement. In a very small minority of cases, the pectinate muscles running to the crux are left-sided with a smooth right vestibule, and that is mirror imagery. But then we have these other two arrangements in which it is the appendages that are isomeric. And in right isomerism, the pectinate muscles run to the crux on both sides. In left isomerism, we have smooth vestibules on both sides. And in my experience, every heart that I have ever seen can be placed in one of these four categories, meaning that it is atrial arrangement on the basis of the appendages that permits us to start the analysis of the atrioventricular junctions. So how do we do that? We ask two questions. How is the atrial musculature joined to the ventricular mass? And that tells us about the connections. Secondly, what is the nature of the valves guarding the junctions? Because they can modify the connection. But we start off by looking at what happens to the atrial chambers as they join the ventricles. And in most instances, each atrium is connected to its own ventricle. And when we have usual arrangement, almost always we have right-handed topology. And that means the right atrium joins the right ventricle, the left atrium joins the left ventricle. So you will not be surprised to know that when we have mirror-imaged atrial arrangement, the ventricular mass is also mirror-imaged left-handed topology when we have concordant atrioventricular connections. And you are all well aware that in one of the hearts that is usually considered to be particularly complex, when we have usual arrangement with left-handed topology, the morphologically right atrium joins the morphologically left ventricle, and the morphologically left atrium joins the morphologically right ventricle. And this is the situation as you see it with usual arrangement, but we can have exactly the same thing with mirror-imaged arrangement when that is associated with right-handed topology. And in these instances, the atrioventricular connections are discordant. Now, it is here where, when we first described sequential segmental analysis, we made a big mistake. Because at that time, we did not talk about concordant and discordant atrioventricular connections. We used the words concordance and discordance. And it was the use of these words that greatly irritated Richard van Praagh. It's a very subtle difference, and we did not appreciate it at the time, because we had not taken on board that for Richard van Praagh, SD or IL was atrioventricular concordance, irrespective of how the atrial chambers were joined to the ventricles. So if a patient had double inlet left ventricle with SD, that was still a concordant arrangement. But in most instances, as you know, when you have double inlet left ventricle, you have SL. And that for Richard van Praagh was atrioventricular discordance, but we wanted specifically to distinguish that as double inlet left ventricle. So we should not have used those words concordance and discordance to describe specific atrioventricular connections. And that is why we had the huge schism that led to this difference between segmental and sequential segmental approaches. Now we have resolved that problem because we never use the terms concordance and discordance. We specifically describe concordant and discordant atrioventricular connections. And we recognize that the connections are plural, two in most cases. So that means we also need to take account of this third type of biventricular atrioventricular connections. Now you'll immediately appreciate that I'm showing you to your left hand, a heart that has isomeric right appendages. And you'll see that is also what you see to your right hand. So why am I showing it to you twice? Because if we take the heart with isomeric right appendages and we attach that to a ventricular mass that has right-handed topology, or if we attach it to a mass that has left-handed topology, half of the heart is going to be concordant and the other half is going to be discordant in both instances. So fully to describe this biventricular connection, we need to take note both of the fact that there is isomeric atrial appendages and the type of ventricular topology. So this is a biventricular and mixed atrioventricular connection. Now, thus far, I've only spoken to you about hearts that have biventricular connections. But you will also know that there is a minority in which the atriums connect to only one ventricle. And in these instances, the atrioventricular connection truly is univentricular. And we can have that with usual atrial arrangement, with mirror imagery, with right isomerism, or with left isomerism. So what are these connections? Most frequently, it is double inlet ventricle. But the univentricular atrioventricular connection is also produced when the right connection is absent or when the left connection is absent. And now we need to take note of the morphology of the dominant ventricle. Because when we have double inlet left ventricle, for example, most usually it is a dominant left ventricle with an incomplete right ventricle. But we may find the same thing when the right ventricle is dominant, the left ventricle is incomplete, and exceedingly rarely we can have the true solitary ventricle. And the same goes for absence of the right or left connection. And of course, then we need to take note of what's happening elsewhere within the heart. But before we leave the atrioventricular junction, let me emphasize the importance of the valvar morphology. Because compare the situation where we have two valves as opposed to a common valve. So to your left hand, you see a common atrioventricular valve. To your right hand, you see the situation where we have two atrioventricular valves. But hopefully, you will immediately appreciate that the presence of the common valve does not alter the atrioventricular connections. It modifies the connections. We also need to take note of straddling and overriding valves, stenotic or regurgitant valves, and in particular imperforate valves. Because look at this heart. In this heart, left atrium connects into the left ventricle. The right atrium is still in potential connection with the right ventricle, but the passage is blocked by an imperforate valve. We have to distinguish that from the much commoner variant of tricuspid atresia, which in fact, when has the left atrium connecting to a dominant left ventricle with absence of the right atrioventricular connection. So now I've explained in quite some detail how we deal with the atrioventricular junctions. We do exactly the same thing for the ventricular arterial junctions. We assess independently the connections, relationships, infundibular morphology. But we have to pick on one of these to be the dominant feature, and that, of course, is the ventricular arterial junctions, because it is the connections that determine the hemodynamics. And they can be concordant, discordant, double outlet, single outlet. So what we are doing is create a cascade of information, starting with atrial arrangement, looking now at the junctions, but taking full note of what is happening in the ventricular and arterial segments, because we can't analyze the junctions unless we also take note of the segments, and only then do we catalog the associated malformations. And then we also take note of cardiac position. And we simply describe whether the heart is to the right, to the left, or the middle, whether the apex is to the right, left, or middle. And if we describe cardiac position In this fashion, we have no problems at all. And I suggest to you that is much better than getting caught up with problems as to what is isolated levocardia or similar terms. So the bottom line, sequential segmental analysis, I still believe, accounts for all cases. It is not that much different from the segmental approach, but it does concentrate on what is going at the junctions, and it is suitable for everyone. Why is that the case? Because it depends only on what you see. And so I now firmly believe that using this approach, we can account for each and every malformation. And I'm more than happy now to discuss that with you.
And that was an amazing tour de force of the last 50 years of nomenclature development. Also appreciate the kind of message of harmony between Andersonianism and Van Praagh, a message I think we need in our world today, as it sounds like both nomenclature systems kind of perfected each other over the decades, which is great. Dr. Gross-Wortman has a comment or question.
Thank you again, Bob. Quick question regarding a double inlet left ventricle situation. Am I oversimplifying it by saying that the mode of that connection is always going to be a common atrioventricular valve?
And hold on just a second. You're muted on your end.
Oh,
There we go.
can
Thank
you
you.
hear me now?
Yes, can hear you.
Absolutely. Certainly, the double inlet ventricle in most instances, I think, has two separate atrioventricular valves. So certain cases do have a common valve. I mean, Richard Van Praagh calls that common inlet ventricle. I don't particularly like that terminology because even though you have the common valve, it's still the case that both segments of atrial myocardium connect into the same dominant ventricle. So to me, it is still double inlet ventricle. So I would distinguish between double inlet left ventricle having two AV valves as opposed to double inlet left ventricle with a common valve. And of course, in that instance, we then have the situation oftentimes when one or other of the valves is straddling and overriding. And then to have double inlet, we need the majority of both atrioventricular valves emptying into the dominant ventricle.
From an imaging perspective, I'll ask the next question. One of the issues I run into is when there's pulmonary atresia and no identifiable MPA segment. You comment on solitary arterial trunk where the PAs arise off the aorta, but times like tetralogy, pulmonary atresia, they're kind of the PAs are independent. How do you describe the interarterial relationships where there's no identifiable pulmonary valve or MPA segment?
I mean, that is the situation where I would describe the entity as a solitary arterial trunk, in that, as you say, you can't identify intrapericardial pulmonary arteries. You also know that in some instances they can in fact be atretic, but you simply don't see them in the clinical situation. To all intents and purposes, I said during my presentation, the arterial trunk is an aorta, but to be totally accurate, I think we should describe it as a solitary arterial trunk, because on occasion we can have a common arterial trunk with pulmonary atresia. It's exceedingly rare. Diane has a couple of cases. I have seen one or two cases, very rarely, common arterial trunk with pulmonary atresia. So you can't be sure if the pulmonary arteries are atretic, whether they would have initially have arisen from the heart or from the arterial trunk. So for purity, if you like, for the purity of nomenclature, I would call it a solitary trunk, but you are correct that in all intents and purposes, it's functioning as an aorta, and we would call it tetralogy. It would be one of the variants of tetralogy with pulmonary atresia.
So I have more of a philosophical question, and honestly, I'm just taking advantage of the fact that you are one of the fathers of the big schism. I'm curious just how we move globally in the field to more of a common language. And I think all of like conferences like these are really important, and we're institutionally, I think, trying to develop that. But do you have any ideas on how we as a field move to common language?
I don't think there is that much difference now. I think perhaps the greatest difference is the fact that, for reasons that I explained, Richard was not prepared to accept the notion of connections. And then he produced to me this nonsensical argument of the connecting segments. But when we analyze the ventricular arterial and the atrioventricular junction, there are no connecting segments. Developmentally, there are connecting segments in that there is the atrioventricular canal, but we know that the atrioventricular canal myocardium ends up in the atrial chambers. It's the vestibule. We know that during development, as we will discuss, there is the proximal component of the outflow tract, but that becomes the ventricular outflow tracts. The proximal outflow segment becomes part and parcel of the ventricles with the development of the ventricular arterial junctions. So in the clinical setting, when we look at the junctions, unequivocally, the ventricular mass extends from the atrioventricular to the ventricular arterial junction. So there's no need for connecting segments. And then we have to accept that the atrial chambers connect with the ventricular chambers. There's no question about that. The blood flows across the atrioventricular junction. So Richard introduced this term of alignments, but these segments are not aligned. They are connected. Think, for example, of tricuspid atresia, which is due to absence of the right atrioventricular connection. The right atrial appendage is still aligned to the right ventricle, the incomplete right ventricle in this setting, but it isn't connected. So I think that to finally resolve the schism, we have to accept that alignments is an incorrect anatomical term, whereas connections is a correct term. And if we simply talk about the connections, I do not think that there is then a problem, providing we also acknowledge, which I have done, that we should not have used concordance or discordance in Van Praguian fashion. And part of the problem also is the fact that those who claim to be Van Praguian do not use Van Praguian nomenclature as he intended it. And the perfect example of that is D-transposition. Transposition IDD is congenitally corrected transposition, but it is still D-transposition. How many people use D-transposition as if they are talking about regular transposition, which is either SDD or ILL? So I think if you're going to be Van Praguian, you should at least use Van Praguian terminology as Richard intended it to be used.
Well, and for the record, I am a diehard Andersonian, so just to put it out.
Thank you for that.
I do have a transposition heart that is so-called D-transposition. Aorta is actually leftward of the pulmonary trunk. So
Indeed, and that is another problem. And in Van Praguian terminology, that of course is transposition SDL. And if you are truly Van Praguian, you should give the full segmental analysis for each case. So Richard said transposition can be SDD, SDL, ILL, ILD, and it's only when you put all the alphabets together that you get proper Van Praguian terminology.
I was under the surgeons here. I was under the impression that when you talk about D transposition and L transposition, the case of the letter matters, right? If you use uppercase D or uppercase L, that's the ventricular topology. Whereas if you use a lowercase d, which is what clinically we use for D transposition, that means aorta is to the right of. So so I thought the lower cases represent the relationship of the great arteries in a loose fashion, whereas the uppercase D or L is the one that stands for ventricular topology. Am I mistaken?
Well, let me give you an example. Think of the patient who has mirror-imaged atrial arrangement, who has right-handed ventricular topology. So the left-sided right atrium is connecting to the left-sided right ventricle. Sorry, the left-sided right atrium is connecting to the left-sided left ventricle in discordant fashion. The left-sided left atrium is connecting, the right-sided left atrium is connecting to the right-sided left ventricle, again in discordant fashion. And in that arrangement, when you have transposition, the aorta, which you're saying is going to be a little d, the aorta is still to the right. So this is still D transposition. Now, is that arrangement congenitally corrected or is it regular transposition? It's still little d. Over to you. What's the response?
So I would have qualified that, it's like you put the parentheses, a fancy parentheses, and then you say whatever, I, D, and then the next letter for the outflow tracks, and then you describe that as, I don't know, D transposition, little d.
Then it's congenitally corrected.
Anyway, I'm not going to argue with you, Dr. Anderson.
But that is the problem with using D and L, because you can't use it accurately to distinguish whether it's regular transposition or congenitally corrected transposition. So it's much easier to talk about congenitally corrected transposition, surely, because we all know what we mean by congenitally corrected transposition, and we can find that either with usual arrangement or with mirror imagery, or if you will, with situs solitus or with situs inversus.
Any other questions for Dr. Anderson? Any questions online? Questions online? All right. Well, that brings us to the end of our didactic talk from Dr. Anderson here from 9 to 10. So we have another short break for about 15 minutes, and then we will get into anatomy session number 2, which is our inlets. I'm sorry, not our inlets, our communications, I believe. Yep, communications are next. And we'll go from there.
Okay, well, thank you. I'll be back in 15 minutes. Gives me time to have a cup of tea.